Hi, everyone, and good afternoon or morning, wherever you might be, and welcome to our third Community of Practice webinar. I'm Francine Maloney. I'm an implementation specialist here at Ariadne Labs, and I work very closely with our Serious Illness Care program. I'll be one of the hosts for this event today. Again, just thank you all for joining. I know you all have busy schedules, and it truly means a lot to have you participating in our webinar today. But first, it's my pleasure to introduce you all to Drs. Daniela Lamas and Charlie Chen. So Daniela is a pulmonary and critical care physician at Brigham and Women's Hospital, and she's a faculty member at Ariadne Labs. And then Dr. Charlie Chen is a hospice and palliative care consultant at the Royal Columbian Hospital and New Westminster. He's also the program director for Adult Palliative Medicine residencies at UBC. Dr. Chen has worked with his team to adapt the guide for the long-term care setting. And Daniela, or Dr. Lamas, has worked to adapt the guide in for chronically ill patients. She'll correct me as I'll go along. So here we are. Sorry, forgot to move the slide. So you see Dr. Chen and Lamas there. Dr. Rochelle Bernacki is also on the line and will be giving a piece of the webinar today, and then there I am. So before we really get started, we just want to go over some webinar functionality, especially for those of you who might be joining for the first time. So as you can see, there is a right-hand panel to your page. There should be a participants chat and Q&A function, hopefully along with a polling function. Please feel free at any time to chat to any of us, either the host, panelists, or anyone else. You can also use that Q&A function, and we will see your questions as well. We do use polls throughout, including that beginning poll if you are here for it, and we will give you the results as we go along. And then finally, in the Participants tab, there should be a little raised hand icon somewhere, although I'm not even seeing it on mine. So if we do have discussion points, and then in order to, if you want to speak out, you can raise your hands and we'll unmute the lines. We do keep the lines on mute just to cut down on background noise throughout the webinar. So again, we hope to really create a lively discussion, so please communicate in whatever style you feel most comfortable doing. If you have any technical questions or concerns or just anything else, you can use that chat to host function, and I can assist you directly. So to reflect back on what we did in the last webinar, we talked about workflows, and we had Dr. Rochelle Bernacki and Joshua Lakin sort of walk us through what that means. And so we learned about workflows and why they're important. We established some workflow diagrams, and then we were able to share examples of serious illness care adapted workflows. One was in a primary care setting, and then one was in multiple settings, actually, but that also involved a research component. So where are we now? We went over this, sort of what we call the roadmap in our first webinar, and will continue throughout this webinar series. So as you might see, adaptation of the guide isn't called out as a specific step in planning for implementation. But it's critically important component that you might decide to do at your institution. And if you do decide to adapt the guide, we would recommend that you do so before building sort of the entire module into your EHR. Should definitely maybe start conversations with the IT folks, but sort of thinking about pieces of adaptations or not finalizing that EHR component will be important. And we will have a webinar on EHR's integration, I believe, in February. So what you've shared with us, especially around adaptation, is that some of you have been changing the setup, which is great. We've heard that be a problem since our first version of the guide. You're adding your logos, which we couldn't agree more with. I know that if I walked into work and saw a logo from another company, I don't think I would pick up the piece of paper and think that I should be using it. That you've asked for an adaptable version of the conversation guide, and there is one available on the community of practice. And then there's been a lot of questions about copyright issues, and we will go over some of what the Creative Commons means at the end of the webinar. So today's objective is to really consider the role of context in having serious illness conversations, review lessons learned from the surgical safety checklist adaptation. We're going to, of course, describe 2 adaptation processes and some lessons learned throughout those. And then we're going to finally integrate lessons learned from current adaptation processes into efforts to adapt in your environment. Most importantly, understanding how we might help you do so. So I'm going to switch it over to Rochelle. Now I'm going to, what we call is passing the ball, so it's going to take a moment. And so Rochelle, oh, I need to unmute Rochelle, that might help. Rochelle, you should be able to control the slides and do that.
Yep. Great. Thanks so much, Francine. Wonderful to have you all here today. And I'm also delighted to have our first guest presenter from outside Ariadne Labs, Dr. Charlie Chen. So thank you, Charlie. And as always, thank you, Daniela. I just have to make a quick note that Charlie was so engaged to give this presentation that he was willing to talk to Francine and I while he was on vacation in Hawaii. So thank you, Charlie. But I think the first objective is incredibly important, considering the role of context in having serious illness conversations. So why adapt the guide? Well, first, patients with serious illness are cared for in different clinical contexts. So in the outpatient setting, in the inpatient setting, or in a nursing home setting, or even in a ICU or an LTAC. So today we're going to be talking about adapting the guide to the use in the LTAC, and also which is a long-term care acute hospital, and also in a nursing home setting. We also adapt the guide because patients have different serious illnesses. So you can see, you know, I'm currently on service and I have a number of patients who are really young. But, you know, the conversation might be a little different if the patient is in their 80s or 90s and has lived a very full life, and they may be more willing and able to talk about their goals and expectations. As you can see, these beautiful women in the middle of the slide. And then, you know, the slide with chemotherapy and a mother, you know, that can be a really different kind of context. So thinking about the questions on the guide and who your patients are is really important to making sure that it's best adapted and suitable for them. The other reason we adapt the guide is because patients are different. So as you can see, you know, we have patients from all over the world, all different kinds of cultures. We have Vivek Murthy, I think, down in the picture in the bottom there. But it's incredibly important. We just received a guide that had been translated into Korean. Now, I do want to make a note that there's a difference between translation and adaptation. Translation is just taking the guide and the questions and translating them. However, you know, if you're working with a different culture, like perhaps in Korea, you may want to think about adapting the questions, and we'll be talking about how to do that. And then the last reason, and probably the most important reason, is this really needs to be your guide. You need to feel like you can stand behind it and really feel like you've made, you know, this is something you are attesting to as being the standard of care. So you can see 2 different examples of the ways that people have taken the guide and made it their own. So the one on the left, that's Medical College of University of South Carolina. So they just put on their logo down at the bottom. So you can see it has Ariadne Labs and then their logo, Rollins Cancer Center. On the right, you can see what the BC Cancer Agency has done, and they've actually changed the colors and the font, and the questions themselves are pretty similar to our questions, but you can see that they've added their own font and made it their own. So why do we need to talk about this? Well, I think what we really want to hear from you is where are the hotspots of implementation, and we've heard about some of them from you, and we're actually going to talk about them. One is the nursing home setting, but I think there's a lot of other places where maybe the guide doesn't fit exactly, and what do you need to do to change it? So we're going to do a quick poll. I'm going to turn it over to Francine.
Thanks, Rochelle. Yeah, I'm just going to take control for 1 second so that I can give you all the poll. So yeah, our second poll is, in which setting have you tried using the guide? We understand that not all of you are clinicians, but if you are, implementing the guide somewhere, you can still choose. And then, have you had experience using the guide that made you think the guide might need to be adapted for use in similar patients? So the poll should be open. You can choose your answers and then submit. And we'll give you about a minute to do that. Okay, everyone, thank you so much for answering the poll. So it looks like about 40% of you have tried using it in the primary care clinic, and so it's actually about 33, 33, 33. So primary care, inpatient, and then other. So we would love to hear from you during our discussion time what those other settings are. And then for the second question, it's about 50-50. So 50% said, yeah, you might want to adapt it, and about 50% did it. So at this point, I think I'm turning it back to, actually, we're going to open it up for discussion. And again, if you want to use your raise the hand, I can unmute your line, or you can use other modes. So would anyone want to share that experience that made you feel the guide might need adaptation, or sort of what happened in those moments? So the good news is our team's very used to allowing for silence. So again, we just really love to hear from you. You can use that chat function, the Q&A, or the raise the hand icon, and we can unmute your line. We know about 50% of you have had experience in which you thought about adapting, and a lot of you have just used it. So we'll give you about another minute, see if anyone's willing to share.
I think we'll go ahead and move on. I'm sure there's people out there that have adapted, and we're going to learn from Daniela and Charlie today about their adaptations, but we'd love to hear from the people who sort of are adapting to other settings. Before we do that, I'm going to go into talking about our lessons that we learned from the Safe Surgery Checklist here at Ariadne Labs. So the Safe Surgery Checklist, basically, you know, it was unrecognized that this was that there was a public health issue, and there was really lack of data on outcomes of surgeries. And what to do was known, but it was not done consistently. So, you know, and so what they did with the Safe Surgery Checklist was to ensure that things like that people all knew what kind of procedure was planned, how long it would take, what the estimated, what the potential complications were, that people knew each other's name in the surgery. But what the lessons that they learned in doing that checklist is that they learned that one size doesn't fit all, and that when people did modify their Safe Surgery checklist, that really created a lot of own-in or buy-in and ownership, so that people really felt like this was they could stand behind this, and this was what they were considering a best practice. It's really important that you include a team in this and include all your stakeholders. So for the OR, that includes people like the surgical scrub nurse, the surgeons, the OR staff, the people who do the scheduling, all those things, all those people should participate. For the Serious Illness Conversation Guide, I think making sure that you have participants, from nursing, social work, chaplaincy maybe, pharmacy, but also from different areas of a hospital or a health system that you work in. We do think that the guide should stay on one page. It's pretty hard to use a two-page guide. And making sure that the main reasons why you have the guide are included. There are certain things that you shouldn't modify, and we do have a whole document on the Community of Practice website that will walk you through what we think can and can't be modified. For instance, we think that you should always do an introduction, and we also think that starting with what your understanding of your illness is really a good place to start. Maybe you'll ask a few more questions, and we'll see an example of that today with Charlie's modification to the nursing home. But there are certain things that we shouldn't change. So we're going to go through those and go ahead and I'm going to pass it over to Daniela, who's going to talk about adapting the guide to patients with chronic critical illness who live in long-term care acute hospitals.
Thanks, not Daniela. She's here, though. Thanks, Rochelle, for that.
Hi, this is Daniela. As Francine said, I'm a pulmonary and critical care doctor, and I do some work in a long-term acute care hospital. Just to explain sort of what a long-term acute care hospital is for people who maybe don't have them in their state or area. Basically, a long-term acute care hospital is a place that takes care of patients who've survived critical illness. Generally, we're in the ICU, but haven't recovered and still have really substantial medical needs, like this photo shows, like needing a tracheostomy tube for prolonged connection to the ventilator. Often these patients are on dialysis. They could be very weak. They could have other multiple chronic conditions. And so while these are places that very sick patients go with really high morbidity and mortality, chronically critically ill patients, half will die in a year after their acute critical illness, there wasn't really any structured method to give these patients sort of practices of palliative care in the long-term acute care hospital. And I was interested in finding out whether having this sort of conversation about goals and values for these patients was even feasible and acceptable to these patients and or their family members, whoever was having the conversation. So how we thought about adaptation at this point, you know, on the face of it, these are a very different population than those who can walk into an outpatient oncology appointment. But, you know, there's practical challenges, as I alluded to before. Often the patients, whether they simply can't talk because they're on a ventilator and mouthing is too hard for them to be understood, they're too weak to write, or they might be really too delirious or cognitively challenged to be able to have this conversation. Also, in the outpatient oncology setting, all these patients sort of share a clear diagnosis. They have cancer. Cancer has a sort of specific trajectory, but these chronically critically ill patients is a sort of final common pathway for patients who've undergone all sorts of problems. And these are patients from medical intensive care units who might have had a really bad pneumonia on top of emphysema. These are patients who might have been in a big car accident or might have had a huge stroke. So very different heterogeneous group of patients with different trajectories. So can we have the same conversation for all of them and make it meaningful? And sort of part of those trajectories is the fact that in this population, it feels as though prognostication is really challenging. You know, while big studies show that sort of half of these patients will be dead in a year, if you kind of hone in on it, that's more true for the patients who had multiple chronic conditions, came into the ICU, got a pneumonia, didn't get off the ventilator, than somebody who was young, healthy, fell off a ladder or something like that. Finally, I was interested in really just finding out if this conversation was feasible and acceptable, and for the purposes of this introductory study, and there will be more studies to come, I hope, I conducted this conversation with the patients myself, and while I do some clinical time at this institution, I was actually not conducting, I wasn't doing it at that point, and I wasn't conducting this conversation as a patient's doctor. So I was really an outside party who came in essentially to elicit the patient's goals and values and thoughts about their illness rather than to deliver prognostic information. So what adaptations did we actually make with all of that? With all that said, well, I think the biggest one, and the one that probably is the biggest barrier to making this a meaningful conversation, was that we didn't frame the conversation with any prognostication. Because I wasn't these patients' clinicians, I really couldn't do that. So we didn't use time-based, we didn't use functional prognosis, nothing. I did not say that question. The other change, which I'll be interested to hear about sort of how else this takes place in your settings, is the fact that we needed to hold a conversation with surrogates. And so really, I mean, in one way, that's just a question of flipping around the language. But in another way, you know, it's a question about sort of how the surrogates understand these questions and making sure that the goals that they're telling you about are really the goals of the patient, not their own goals, and that's sort of hard to parse out. There are also sort of smaller changes. You know, one, the trade-off question, I really tried to focus this on the most likely trade-offs that the patients would undergo, really focusing around the question about whether they had a setback that would spark a return to the acute care hospital. The rest of the questions sort of kept as is. So what happened? So I ultimately talked to 50 participants. The majority of these were patients. There were 30 patients, 20 were surrogates. And when we asked them afterwards, most of them, 82% of those who we talked to, said that they considered the conversation to be worthwhile, and self-reported said it didn't increase their anxiety, and in fact, maybe led them to feel more hopeful or peaceful. You know, interestingly, we fed back all the themes that came out to the clinicians, and what patients said really was that they described a poor quality of life at the current moment, but they had these specific goals for their recovery, and these were goals to get back at or near their prior level of functional status. You know, a majority of these patients said that they expected to go home, and we ultimately followed these patients out a year's time, and only a third of them were home, and of those, not all were functionally independent, which really did not line up clearly with what they told me that they wanted at that one point in time. At that time, we then also summarized and fed back what the patients said to their clinicians, and the clinicians, when asked, said that this conversation summaries really did offer new information about what care would look like for these patients in the setting of a setback, so it was valuable. So what we learned from this sort of small study that, again, I really hope will lead to further study in that setting, is that the conversation is feasible and acceptable to a group of hospitalized, seriously ill patients, that it can reveal clinically significant insights, and interestingly did that, even without the prognostic sharing. Though it is more difficult to frame the conversation without at least some sort of general prognostic information, I think that will be valuable moving forward. And finally, I really felt that there were points at which, if I was this patient's clinicians, I would have been able to sort of jump in and push them a little more on what they were saying, in terms of sort of honing in on the fact that some of these goals that they were offering me seemed really sort of poorly aligned with the realities of their clinical conditions. And so I think that really speaks to the importance of a conversation being delivered by a member of the care team, particularly one who's able to circle back and pick up on things that a patient said and reassess those things over time. So I'd be interested in passing this back over to Francine.
Yeah, and Daniela obviously is here throughout, so if other people have similar experiences or questions about it,
yeah, and I'd be really happy to just write in.
So we're going to switch over to Charlie's experience in the nursing home setting. So Charlie, I'm going to sort of give you the privileges, hopefully. I'll do that now. And I will unmute your line in the process. So, Charlie, can you hear us?
Yes, hello.
Oh, hello.
I'm thrilled to be here. Thank you so much for having invited me. And I was getting a little bored in Hawaii anyway, so it was wonderful to connect with you, Dan. It was my pleasure. In our health authority here in British Columbia, Canada, we've really noticed that many of the residents who come into long-term care facilities have not had adequate advanced care planning, or even if they did, there was poor documentation. At the same time, we discovered that there was a real need to embed the philosophies and practices of earlier palliative care integration into the care for these patients. Considering that their length of stay average was about 20 weeks, patients really do not leave long-term care, and therefore pretty much all of them will require palliative care interventions at some point in their stay in the long-term care facility. So we embarked in a multi-year initiative to integrate palliative approach to care into these facilities. And of course, one key strategy was to promote and improve advanced care planning, goals of care conversations, and the serious illness conversation guide really seemed like a natural fit. And the context of that is that really 2/3 of our res care patients have dementia, and almost all of them have some form of cognitive impairment. And many of them, therefore, have limited or no capacity to engage with advanced care planning or future planning, or even in the moment decision-making in terms of these big questions. And we know that capacity is fluid, so they may have capacity for simpler medical questions and treatments, but for these big things, they did not have full capacity. So we needed the substitute decision makers to be actively involved. In BC, we call them substitute decision makers. In other jurisdictions, it's proxies. So we needed these SDMs to be actively involved in having these serious illness conversations. And most often, they turn out to be family members. So we created a QI project to test the adaptation with physician users, and then to assess and evaluate a training workshop that informed them of how to use this guide. And we sort of flipped it compared to what Danielle was talking about, using it first with patients with one clinician. We try to disseminate to more clinicians and see if there's buy-in even from the clinician's point of view. So here's a little bit of a flow diagram that Francine very kindly constructed for me out of my jumble of words. So initially there was a creation of an adaptation, and I was very, very careful to ensure that the tool that was created allowed the patient's voice to really ring through. And to protect this vulnerable, frail population. And as Danielle alluded to really make sure that the substitute decision makers' thoughts that we captured were as reliable as possible a proxy voice for the patient's goals, values, and priorities, and not reflective of the SDM's own opinions. So that was highly, highly important. And I, along with my collaborators, a shout out to Dr. Nick Petropoulos, as well as our clinical nurse specialist, Susan Brown. We used the guide and tested it ourselves with our own patients and came back as a small group and then revised it some more. And then ultimately, we adapted a existing 2.5-hour serious illness conversation guide training session. Again, here, a shout out to the BC Centre for Palliative Care, who set up the initial 2.5-hour training for capable adults, but we adapted that to use with our SDM adaptation. And we went about training cohorts of physicians. Our first cohort was 14 physicians. Our second cohort was about 20 or so physicians, and our third cohort was 15. And we had the luxury of doing a 2-month follow-up session with the first cohort, and we're about to do a 2-month follow-up session with the third cohort, but the second cohort didn't quite have enough buy-in to do more data collection. We administered pre- and post-training session surveys, and then, of course, the 2-month follow-up session. And we collected both qualitative and quantitative data. How many conversations did you have would be a form of quantitative, and what was it like using it? What were challenges and barriers? And I'm going to share a little bit of that data with you. And then next step would be to then go ahead and survey the actual substitute decision makers with whom we used the guide to see how feasible they thought it was and how helpful. And there is a proposal underway where we are going to indeed move forward with a survey of substitute decision makers who've had the conversations. Most significant changes to the original guide was the insertion of a question fairly early on to capture any previous advanced care planning conversation or documents that the substitute decision maker may be aware of. And I thought that was hugely important, considering that a lot of people have had advanced care planning conversations, and they're throwing the ball into the air, and healthcare providers are just dropping it left, right, and center because we failed to ask about previous considerations. And then the second part would be all the key topic questions are all flipped into the third person, phrased in a very specific way. So in circles are the changes, and you'll notice that in red, step number 2 is my insertion of explore prior conversations in any advanced care planning. And the question is, how much has your mom, for example, discussed with you about her priorities and wishes, especially about her health and illness? And that really allows us to capture any previous advanced care planning, maybe ask around any documents, and we have some legalities in BC, such as representation agreements or advanced directives that are all legal entities that we must ask about. So that's a prompt for that. And then all the questions flowing from that are flipped into the third person, especially in the key topics. So rather than asking, what do you think your mom's most important goals are if her health worsens, that's not really what we want to know. We want to know what the daughter thinks the mom would say. So I often say, pretend that your mom is relatively well and sitting here beside us. What would your mom say would be her most important goals if her health worsens? If she were sitting right here and talking to us, what do you think she would say are her biggest fears and worries about the future with her health, etc.? And that way, we really allow the patient's voice to ring through and stay alive, even if they are not able to fully participate with these conversations. The question immediately at the end of the workshop, we asked them, now that you've seen the guide, you've practiced the guide with role plays, what do you think are potential barriers? And 2 themes readily emerged right at the end of the training workshop. Time, just how much time they may or may not have to squeeze in all of these great questions, and then when to incorporate these conversations into care conferences. Do we have to set up a separate time? So that was a major theme. And then a major theme was ongoing training in the use of the guide. And even though they felt confident using it now after even 1 training session, they thought that they needed probably more coaching along the way, or else they might revert back to usual questions and care. And some of them thought that they needed more practice to make it feel less scripted. and it's not included in the slide here, but I will just say that one of the strategies that we've come up with that we have yet to capture more data about, we're now making this much more interdisciplinary so that other people can have these conversations, not just the physicians, to alleviate some of the time constraints. So we provided some quotes here because I thought they were really nice to indicate what the feedback was. And this is feedback from 2 months after the initial workshop for cohort number 1. I tried it in clinic, and I liked how I knew what the next question was and helped steer me back to the next question if I was going off track. And we've heard that even with the original guide, how the structure was so helpful. Second quote, it felt like a simulated checklist, which it is. I tried it, and I may do it differently, but nice to have a structured format, hit all the points, steers decision-making. And that was one of the points that we were trying to make, is that these are earlier conversations, not earlier decisions, but ultimately, if you gather this information, it can really help steer decision-making in the future. These are quotes about challenges. And this surprised us a little bit. So one quote was, what are functions that are so critical to you, mom or dad, that will inform quality of life? They needed to offer elaborations and offer concrete examples. Family just answering that question. And then I found patient preferences needed more explanation when I spoke about function. Patients had difficulty understanding. And I would say patients here represent substitute decision makers had difficulty understanding. And that's what we found, is that the key topics, as straightforward as they are for many of our capable patients, for substitute decision makers, they're surprised by how little they know about their loved one. They think they know their loved one, but when it comes to these questions that actually inform medical decision-making, they feel a little lost. So they were surprised by that, and we were surprised by that. But certainly there were lots of successes. Hearing and finding out about what the residents want, there is therefore no mystery. This is exactly what we want. It means that the patient's voices are ringing through. Everyone is on the same page. There's a common language for family, residents, peers. And what was interesting here is that a brother and a sister had different views. So these questions allow them to come together and have a common language to have conversations. And it focused their conversations to really serve their parent much more clearly, rather than just making decisions based on their own perspectives. So what did we learn? We learned that the majority of the initial workshop participants found the training quite adequate to go ahead and use the guide. And we employed this QI, PDSA, rapid cycle feedback to adapt the guide to ensure that what we were using was going to be true to the original intent and true to the vision, but had local adaptability. And as I mentioned, the key priority section was more challenging than we thought, and ongoing coaching and modifications to the training will be required. And in fact, we have done that. Even from cohort 1 to cohort 3, we've actually modified our training to put a little more emphasis on the key priorities in the role plays. And then in the follow-up session that's going to happen in February for cohort 3, we are going to explore these challenges a little more. And again, even with our training, there's been rapid PDSA evolution. And as I mentioned before, our next plans are to do a little bit of a study to survey substitute decision makers who have had these conversations and determine from them how helpful they thought it was, how feasible the guide was, etc.
Thank you so much, Charlie. I know that I already learned a lot just from hearing your experience on that process and that project itself. So again, we want to move to a discussion section. A few questions and chats have come through, which is great. Keep them coming. So the discussion we had here was what questions or comments do you have about the way that both of our presenters went about adapting the guides in these populations, but feel free to ask other questions that are on your mind. So we're going to start off about whether we can talk more about interdisciplinary work with others having the conversation. It sounds like I know both Charlie and Rochelle, I know that you have a lot of experience with this, so if either one of you want to talk about your experience with that.
I'll start a little bit. We are actively empowering the patient care coordinators, clinical nurse educators, and even training social workers and frontline nurses to use portions of the guide. What we have found is that they feel uncomfortable with even functional prognosis, but once the physician has had a chat with the family and given the medical information and the prognostic piece, they can come back and reinforce the functional prognosis, which they feel comfortable with, and then help with delineation of the key priorities and key topics. And then they would have more time to actually use concrete examples and explore around that. And maybe even go back to the patient with the family members and ask the patient in however capacity he or she has to explore some of these key topics as a care team, which I think is wonderful to really make sure that the patient's not lost. And then to step back, in our intake, we are trying to incorporate the initial questions about what do you currently understand about your brother's medical condition and how much information would you like to have, and then also embedding in intake, what are you aware of in terms of your mother's previous advanced care planning, prior wishes and priorities that she's already expressed. So we're breaking up the guide and putting it in various parts of a patient's journey, intake, care conference, separate conversations about key topics, and utilizing different team members, and then documenting all on the same place, which is in my health authority, the advanced care planning record form.
Great. Rochelle, I think it's a similar story, but if you want to share maybe a little bit about either, or the work in Brigham and their interdisciplinary model?
Sure. Yeah, so we had, you know, I think the key thing is it does need to be a team. And in our interdisciplinary work that we did at the Brigham, we worked with care management nurses, and some of the more experienced nurses did feel comfortable sharing prognosis, but not some of the younger ones. That was just what we saw. But I think it really depends on your setting and whether or not that works. But I think the one thing that's really important, if the nurse, if our care management nurses were going to do that, is that they had buy-in from the physicians that they were working with to have those conversations. And we also have set up a structure around coaching for the team. So we have myself and Josh Lakin are available for the care management RNs and the PCPs about having these conversations. And so we would often and we'll sometimes, if we have a resistant kind of clinician, we'll sometimes step in and check in to find out what's going on with this particular patient. And oftentimes the reason maybe a PCP doesn't want to discuss is there's already a lot of people in the mix, but we'll go in and sort of back up the care management nurses. But there's been, I would say that it is an area where there's a lot of variety and sort of scope of how comfortable people feel discussing something like a functional prognosis.
So this question actually follows nicely to that. So, someone asked, it was actually Sue, Sieko Ismu. I apologize if I mispronounced your name. She asked, when we talk about patients in primary care setting, the prognosis is not necessarily as bad as in the guide, and they have some difficulty on how to rephrase it for patients with not so short prognosis. I think, Daniela, your prognosis is also uncertain in your setting, but we also heard Charlie talk about the functional prognosis. Do you want to talk more about uncertainty and how you've seen that play out?
Sure. I mean, I think that that's a big challenge, and I think that that's a question that I actually, I'll try to answer, but then also could defer to Rochelle a little bit about to talk about the primary care and sort of hospitalist patients. But, you know, I think, I mean, in the long-term acute care hospital setting, like to be in there, something horrible has already happened to you, and there's the chance of something bad happening again. And so there is actually like something concrete that you can sort of hang on, even if you don't know exactly what it's going to look like. It could look like a range of things, like you could get better but not the same, and also you could be worse and it would look like sort of the way it looked before. But I think that even sort of navigating that uncertainty is hard, and I think the best that I could think of doing is really sort of painting out the range of what is possible, and then getting patients to start thinking about what they would be willing to undergo, given the sort of range of what is possible. You know, I think getting somebody in the LTAC setting, getting somebody to realize that they're not going to be home as functionally independent as they were before, if that's the case, like that in and of itself is a value. And then thinking about, you know, what's important to them given those limitations. But I'll defer to Rochelle for a little bit more on that.
I think that's exactly right, Daniela. I think, you know, sort of giving people an idea of the, being, first of all, transparent that we aren't certain, but sometimes even our degree of certainty is much more than the patient's degree. So if you give a range of potential outcomes, you know, just letting someone know that they're not going to be getting back to their, you know, to their house potentially is enough for them to think about the conversation differently. And I think the other piece that's really important to think about is essentially just starting this conversation is really hard, and I think the guide does a really good job of that. It gets the conversation started. It also gets a lot of the important issues on the table, but it is an iterative process. So just because you ask the questions on the guide, I think, you know, you sort of uncovered a lot, but it requires ongoing conversation.
Great. So just to keep moving, I want to make sure we hit all of our objectives today. Again, keep sending your questions in, and we will try to answer them either in real time or we will be sure to get you all the answers after the webinar as well. So to move on, objective 4 today is really to integrate the lessons learned from current adaptation processes into efforts to adapt in your environment. So move on. So really thinking, we've heard a lot about timing and balancing proactive and sort of reactive changes. So we heard about Charlie's process, and it began with a very proactive, what should we change about this guide given what we already know about the setting that we're going into? And there's a lot of benefits to this. They identified some very obvious changes that would overcome immediate barriers. And they knew that it would create buy-in from multiple stakeholders in the beginning. I know I sort of joked at the beginning about adding a logo, and those are very easy changes, but it can matter. But also, like, they added about the question about ACP documentation. And that's also sort of, as he mentioned, a requirement in their setting. So not having it in there is very proactive and it's beneficial. There's also risks, though, and sort of we've seen this ourselves doing it, is you might make changes prematurely. What we think is a good idea to change might not actually help, and then might reflect our own biases. And this process can be slow, just because you're thinking of all the possibilities that might help. And then there's the reactive process. Again, Charlie's group did this. We do this a lot. So after you've gotten started, you start to hear the feedback, or you have gotten some survey results, and you then go back and change based on what you've heard. So again, there's benefits to this. One is you can get started quickly. This assumes that you didn't do any proactive work, of course. It is based on actual feedback, and you get to hear these hotspot issues over and over and change it, and it's relatively fast. The risks, again, is you may not know what you're missing until it's too late, which could upset some people, and then in that you might miss the perspectives of key stakeholders. So Rochelle mentioned this at the beginning. I think it's worth re-mentioning again, but adaptation is, it definitely is different than translation. So when we think about translation, here's 2 examples here. It's pretty much a lot of times language translation. So I'm not even, I can't recall now what the Coca-Cola one says, but it translates into bite the wax tadpole, or the female horse stuffed with wax, if you were to do a trait translation. It's happiness in the mouth is the more appropriate version when translating. So if you want to do a straight translation, typically you do a forward translation, and you get an expert panel, and sometimes you do the back translation, but you just to make sure that it makes sense now, that you don't get bite the wax tadpole. And then you do want to do some pre-testing and cognitive interviewing and have the final version. But then there's the adaptation process, which is what we heard about today from Daniela and Charlie. And this is more of an iterative process, and it may or may not include translation. And it also includes, it considers all those local contexts and meaning with the words, meanings of the words. So when thinking about, we've gone through and actually thought about timelines for these translations can be pretty straightforward, and if you have someone that you work with to translate things regularly, it could essentially take about 2 months or less. The adaptation process tends to be more of a project, we would say. If you first initially need to translate, then you would do that first. But then you would go through that process that Daniela and Charlie described. And so that might, who knows, but it might, again, in that proactive state, take 4 to 6 months, but you may move faster. And then there's the approach to doing it, and I think what's nice is, from what I understand, we heard the 2 different approaches today. Daniela's was more a research approach and learning about how this guide works in the long-term acute care setting. And so hers did go through an institutional review, and it was a little bit slower. It took about a year.
Yeah, something like that, yeah.
There was a paper that came out of it. And then there's the quality improvement, and we heard the amazing team that Charlie had put together. He mentioned the PDSA cycle. It's more real-world sort of setting, not that SpellPack isn't the real world. And that doesn't mean they won't produce a paper and let the world know what the amazing work that they have done. We'll see. We could all definitely learn from them. So in terms of the future of adaptation and what we're sort of thinking about even now and trying to work on, we have been working with people here on Spanish-speaking, partnering with other organizations to do proper Spanish-speaking adaptation. And again, this is adaptation of the guide and not straight translation. We want to make sure we account for all those contextual factors when translating into Spanish. And then we, of course, Daniela highlighted, but also different institutional care settings. So we have been working in a hospital, but also ICU-based clinicians, which is, of course, what Daniela is. And there's very high demand for similar types of interventions as this. And then clergy have also been working with us in our interest in adapting the guide as they commonly engage with seriously ill patients and have minimal training to do so. We're, of course, interested in hearing or partnering with any of you regarding adaptation. I will say we've been in contact with a lot of people about translation as well, which is always exciting, and the more that we can spread any translation that's done and help others, we would be happy to do so. And then finally, what tools are available for you? We want to try to give you guys as much of a head start as possible. So on the community website, we do have some customization principles, and I will say it's fairly consistent with what, if not exactly consistent with what Daniela and Charlie mentioned today. And it's just really about keeping the essence of the guide, keeping the open-ended questions and providing a rationale for why the questions are there and why even the order in which they are in. And with that, there's also the customizable version of the Serious Illness Conversation Guide. Of course, we heard from a lot of you that a version of that would be helpful in your work. And finally, there are notes about the Creative Commons license in a very, at the most high level, for you to know, the Creative Commons license does allow you to adapt the conversation guide in any of the materials in which the Creative Commons license is on. And then it requires you to attribute the materials, if you do adapt them, to Ariadne Labs and note that you've modified them. And then it does not allow you to make a commercial profit or a profit off of the use of our materials. Those are like the most high-level 3 pieces of what it even means. But there is many more notes, and it explains the full information about the Creative Commons license in the community website. But we would also really like to hear from you about what else you need. What will help you adapt your tools? So we're hoping this question starts that conversation, or this poll, my apologies. So this poll is just simply asking, of the following projects, which most suit the goals for your practice environment, or which would help you in your everyday work. So I'm going to open this poll now. You'll have about a minute, and I'm going to look through, if you want to chat any more questions, I'm going to look through those so we can try to answer them for you. Okay, thank you all so much for completing the poll. It's just wrapping up now. It takes my computer a minute, and I can't do anything else. So it looks like most of you, so 55% of you said hospital inpatient. This is not outside the norm. And 45% of you said other. I am going to ask you now. So we're going to move on. There is a discussion piece, but while we do that, I'm going to continue to move on to our slides. And I'm going to move on to our last poll, just given the time. I want to be respectful of your time. And this is both like whether the webinar met your needs, and then if the webinar didn't, what did we miss? And this is an open-ended response. My apologies. If you want to type in what those other projects or what those other adaptations would be helpful, feel free to throw that in that open-ended response. We would love it. So in this remaining time, I just want to make sure if they, so someone actually did already tell us they would love to explore adaptations in the pediatric and neonatal patients. I've actually heard this quite a bit. So if other people are out there and are also looking to do pediatric and neonatal, please feel free to email me directly or post on the community of practice. Charlie says that yes, there is PEDS work going on in BC as well, so let's try to connect you guys because we're not doing it currently at Ariadne, so let's try to get you guys connected. And you can also post on the community site, and I can try to connect you all that way. Oh, and I have Charlie's email, so I can send, we'll be sure to connect you. Let me also just see if there are any more questions. So someone had another question to Rochelle, sorry, and Charlie regarding training nurse care managers or other team members. Was there anything you did differently from training physicians? Do you do anything to gain support from physicians for nurses to have conversations? I know Charlie answered that everyone received the same training, especially even people who did the portions of the guide. Rochelle, did you do anything?
Yeah, so I would say that we did with our nurse care managers, we did some fun stuff where I played the sort of resistant clinician, and we had some of our more creative and experienced nurses use different techniques or just model different techniques of how they got me to do stuff that I didn't want to do. So I think that was useful. We spent about a half an hour. We actually made the training a half hour longer and tried doing that. But we basically did the same training, and we're actually thinking about whether there should be what particular aspects maybe should be revised for that, but for now we've been doing the same thing. The other thing I wanted to say, someone asked about leadership being bought in, and Charlie was lucky enough to have great leadership buy-in, and I think that helps you move along so much more quickly. But I think you know, I was just on the phone with someone else in this community yesterday where she's in the same position where she doesn't have leadership buy-in, and what we decided was that she would try in a very small clinic to do a training and to get some sort of ground-up movement. And I think that's a good strategy. I mean, the other thing with doing that is you can get a little experience under your belt. You don't need a ton of resources. And then, you know, the other thing to remember is that leadership can change. So then you're sort of ready when it does happen. So those are my sort of notes of what to do when you don't have great leadership support.
Thank you so much, Michelle, and for seeing that question. So just to wrap up, our next webinar is January 23rd, and it's on patient identification. We have the honor of having Dr. Joshua Lakin back to talk about it, who's been doing a lot of work in this area, as well as Lee Zhao, who is an informatician working on natural language processing and helping to identify patients at high risk of dying. And I know someone else asked a question about how to integrate into the EHR and have these conversations. And that webinar will be on in February. I don't have the exact date with me at the moment, but we will talk more about EHR integration, and we'll actually have both Cerner and a Cerner person here in Epic, one that has implemented directly, and then actually someone who's working at Cerner. And finally, we just really want to thank our presenters again for joining us today and sharing their experience of adaptation. We will provide this recording and all the slides on the Community of Practice webinar, and we will be sure to answer all of those questions that came in, both either on the forum or in another way. We want to make sure we get you your answers. But again, just thank you all for joining. It was a great webinar, and we'll see you next year.